Hi, let's talk about the pharynx. In this video, we'll talk about the boundaries, contents, muscles, vasculature, and innervation of the pharynx. The pharynx, or colloquially the throat, is part of the aerodigestive pathway, which also includes the mouth and oral cavity. So the pharynx is going to be contiguous with the nasal cavity, with the oral cavity, with the larynx, and with the esophagus. And so everything that I'm outlining now is the pharynx. It's divided into three sections. There's the nasopharynx, which is contiguous with the nasal cavity. The boundary between the two being the choani. The boundary between the nasopharynx and the oropharynx is the continuation of the soft palate. The oropharynx can be divided from the oral cavity by the palatoglossal folds, which come together to form the palatoglossal arch. That's the palatoglossus muscle that's invested with a little bit of mucosa. Inferiorly, the oropharynx is divisible from the laryngopharynx by the pharyngoepiglottic fold and the epiglottis, and this is going to go out laterally, so I'll just erase that and maintain that line there. And then the laryngopharynx is going to be separable from the larynx by the laryngeal inlet and separable from the esophagus at the inferior border of the cricoid cartilage, which is right there. And that's approximately at the level of the sixth cervical vertebra. So let's take a look at each of these sections and see some of their more important contents. So the nasopharynx. On the roof of the nasopharynx is a little bit of mucosa-associated lymphoid tissue known as the pharyngeal tonsil or the adenoid. The pharyngeal tonsil is generally at its most developed point in adolescence, and then it involutes and atrophies thereafter. You're probably not going to see it in most cadaveric specimens, but if it's present, it will be on the roof of the nasopharynx there. There's also an opening, and that opening is to the distal portion of the pharyngotympanic tube. So the pharyngotympanic tube is probably better known to you as the eustachian tube, also known as the auditory tube. This is a pathway between the nasopharynx and the middle ear so that one may equilibrate pressure within the middle ear cavity. So sometimes with an upper respiratory infection, the mucosa may become stuffy there, and one might feel as though their ears are a bit stuffy as a result. This is also a potential pathway for pathogens to enter the middle ear, and it's an important pathway for materials to drain from the middle ear as well. The oropharynx is sort of in the middle of all of these things. So if we were to draw that line through the soft palate, we can see how it divides from the nasopharynx. We have a little bit of an extension of that soft palate that hangs inferiorly. That's called the uvula. So if you've ever looked inside your mouth in your oropharynx in the mirror, you can sometimes see that uvula there. That's a muscularized bit of mucosa. Anteriorly, the border is the palatoglossal fold. If we go posterior to that, there's also a palatopharyngeal fold. That palatopharyngeal fold and palatoglossal fold encompass a space known as the fauces. Fauces is Latin for throat, and I know that the pharynx is also colloquially known as the throat, but this is a portion of the throat. In the lateral aspect of the fauces there's a tonsillar fossa that contains the palatine tonsils. Those palatine tonsils are the collections of mucosa-associated lymphoid tissue that people typically refer to as the tonsils. And so if you're having a tonsillectomy, it's usually these that are being removed. Inferior from this, and we can't really see a good view of it, there's a little bit of the of space there that are known as the epiglottic valleculae. They're not very well imagined here from this illustration, but coming up I'll show you that. And on the root of the tongue is the portion of the tongue that is associated with the pharynx. We have the lingual tonsil. So there's mucosa-associated lymphoid tissue on that posterior 1/3 of the tongue. The other part of the tongue there, that would be the pre-sulcal part of the tongue. The post-sulcal part of the tongue is also the root of the tongue. And so we've got that boundary, the pharyngo-epiglottic fold in the epiglottis that divides the oropharynx from the laryngopharynx, as we'll see. But first, let's take a look at those epiglottic valleculae. So here is the root of the tongue, and we can see that it comes into contact with ligaments from the epiglottic cartilage, or the epiglottis. So looking at this anteriorly, so there is the epiglottis. Here is the root of the tongue, and this very rugose lingual tonsil we can see throughout there. There's the terminal sulcus, so here's the pre-sulcal part of the tongue, and then the post-sulcal part of the tongue is beyond that. And looking between the epiglottis and the root of the tongue, we see 3 folds. There are 2 lateral glosso, meaning tongue, epiglottic folds, and then there is 1 median glosso-epiglottic fold, and then between these folds are 2 scoops of spaces. These spaces are the epiglottic valleculae, and what happens is they serve as a trap for saliva. So saliva accumulates in those epiglottic valleculae, and what that does is it prevents the saliva from entering the laryngopharynx, where it could trigger the deglutition or the swallowing reflex. This is a really important landmark for laryngoscopy, or when you visualize the landmark, or when you visualize the larynx, because the blade of a Macintosh-style laryngoscope goes in there, and then one can pull the tongue anteriorly and look down into the larynx. So here is Waldeyer's ring as a cartoon. So there's an oval here. The superior portion of this oval is the nasopharynx. The inferior is the oropharynx. This dotted line between them would be that plane of the soft palate. So within the nasopharynx, we have the pharyngeal tonsil. We also have tubal tonsils that are associated with the pharyngotympanic tubes, the opening there. Within the oropharynx, we have the palatine tonsils within the fauces, and we also have the lingual tonsil at the root of the tongue. So altogether, these are going to form what's known as Waldeyer's ring, and this is a ring of mucosa-associated lymphoid tissue, or MALT tissue for short, that is going to come into contact with any of the elements that are either ventilated in or consumed in, and so any potential pathogens have to encounter the lymphatic system, and there's an opportunity for mounting an immune response as a consequence of that. So this is very handy. So moving right along to the laryngopharynx, the laryngopharynx is going to contain the epiglottis. There's also a very nice laryngeal inlet, and so this is going to be for the exchange of air during ventilation. On either side of the larynx, and so we can't see that owing to the fact that this is more of a mid-sagittal view, but deep to this or superficial to where we're looking at, there are two recesses. These are called piriform recesses, and when we see a more posterior view, I'll be sure to point this out. And then the opening for the esophagus. So distal to the larynx is going to be the trachea. Distal to the laryngopharynx will be the esophagus, and so this sets up that relationship of having an anterior trachea and a posterior esophagus as they traverse the neck. So here is that posterior view that I was discussing. This is a very common dissection approach for visualizing the larynx, and we can see the various divisions here. So here are the choani that are separating the nasal cavity from the nasopharynx. Up here on this roof there would be the pharyngeal tonsil. Here are the openings of the pharyngotympanic tubes and associated tubal tonsils there. Here is the soft palate. There is the uvula. The root of the tongue would be in there. The epiglottic vallecula would be just on the other side of the epiglottis there. And we can see better now that pharyngoepiglottic fold, the epiglottis, and the other pharyngoepiglottic fold, which are going to be that boundary between oropharynx and laryngopharynx. That's actually complements of the medial border of a muscle called the stylopharyngeus, which we'll see shortly. On either side of the larynx here, we can see those piriform recesses. And so food coming down into the laryngopharynx can sometimes get trapped in these piriform recesses, and that can feel very, very uncomfortable. And so there's the outline for the larynx. This would be obviously invested by mucosa over this musculature, and then the continuity of the pharynx inferiorly, the esophagus. So the muscular walls of the pharynx are formed from two sets of muscles. There are more superficial pharyngeal constrictor muscles and then more deep longitudinal muscles. The pharyngeal constrictor muscles are three sets of constrictor muscles. These serially constrict to squeeze materials through the pharynx. The superior one runs from the cranium out to the sphenoid, the medial plate of the sphenoid, and then this creates a pterygomandibular raphe there, and we can see the remainder of that superior pharyngeal constrictor there. And so this is attaching posteriorly along a midline raphe, anteriorly to a pterygomandibular raphe, and to both the cranium and the mandible, and a little part to the tongue. And so this nests within the next pharyngeal constrictor called the middle pharyngeal constrictor that runs from that midline raphe out to the hyoid bone. So superior pharyngeal constrictor attaches to the skull, middle pharyngeal constrictor attaches to the hyoid bone, and then the inferior pharyngeal constrictor attaches to the larynx. We can see the superior, the middle, and the inferior pharyngeal constrictors here in a posterior view, as well as that midline raphe for the pharyngeal constrictors. We can also see, this is sort of the exception to the rule of the longitudinal muscles being deep. This is a very important muscle called the stylopharyngeus muscle. It originates on the styloid process of the temporal bone. It attaches to the pharyngeal wall and to the thyroid cartilage of the larynx. And it's important for a couple of reasons. One, it kind of insinuates itself between superior and middle pharyngeal constrictors, which makes for a very excellent landmark. Two, you're going to find cranial nerve number 9, the glossopharyngeal nerve, riding down upon stylopharyngeus muscle. You can also see a little bit of the hyoid bone there. So that's the stylopharyngeus muscle. We also have palatopharyngeus coming from the soft palate, and salpingopharyngeus. Salpinx means horn, so this looks like a horn. So these two muscles blend together, and they come down, and they insert both on the larynx as well as the wall of the pharynx. Now these longitudinal muscles, they're going to elevate the larynx. So what that does is it pulls the whole pharynx upwards, so it both foreshortens it and widens it. And so that is going to work with the pharyngeal constrictors to help move food materials through the pharynx. Now the pharynx is innervated by the pharyngeal plexus. This is a neural plexus that has 3 inputs. There are efferent inputs. Efferents are the motor inputs. Afferent inputs, that's the sensory, as well as sympathetic inputs. So let's take a look at the efferent and the afferent now, because they are the lion's share of the innervation here. So efferent, it's all about vagus. Vagus is coming down through the carotid, through the jugular foramen. So the jugular foramen is going to conduct cranial nerves 9, 10, and 11. So glossopharyngeal, vagus, and accessory, as well as IJV, the internal jugular vein. So we can see vagus coming down here. It's going to be bound within the carotid sheath, which is IJ, vagus, and the common carotid artery. And we can see vagus sending branches out here. It's very thick over the middle pharyngeal constrictor, but these kind of go every which way. So this is going to be the efferent, or the motor, to the pharyngeal plexus. And this is going to serve all of these muscles with the exception of stylopharyngeus. Stylopharyngeus is efferently served by the glossopharyngeal nerve, cranial nerve 9. And you can see from its very close association that it's a very efficient anatomical and functional relationship that these two have. Speaking of glossopharyngeal, the glossopharyngeal nerve also comes down to participate in this pharyngeal plexus as the afferent to the plexus. So 10 is the efferent to the plexus, and 9 is the afferent from the plexus. So it's going to serve all of these muscles and the mucosa as well, everything with the exception of the nasopharynx. The nasopharynx is actually served by a branch of the maxillary division of the trigeminal nerve, also known as the maxillary nerve, also known as V2. It sends out a pharyngeal branch which serves the nasopharynx. So stylopharyngeus is one exception to the pharyngeal plexus in that the plexus does not innervate it. The nasopharynx is another exception to that plexus. It also probably bears mentioning that this pharyngeal neural plexus is also going to innervate the muscles of the soft palate, with the exception of one. And that one muscle of the soft palate that is not innervated by the pharyngeal plexus is tensor veli palatini. Tensor veli palatini is innervated by a branch of V3, which is the mandibular division of the trigeminal nerve. So let's take a look at the sympathetic input. There are some branches from the superior cervical ganglion of the sympathetic trunk that make their way into the pharyngeal neural plexus to supply the sympathetics there. It bears mentioning also that there is a pharyngeal reflex. This is probably better known to you as the gag reflex. And what happens here is some stimulus that is encountered by either the Oropharynx, sometimes even the tongue, can send a message along back to the central nervous system through cranial nerve 9, which is glossopharyngeal. And that's interpreted as an unwelcomed stimulus. That means that whatever is there causing that stimulus should not be there. And so coming out the vagus nerve is the response, which is to immediately tighten the muscles of the pharyngeal plexus. You might think of this more along the lines of this sound. And what's happening there is the tensing of the pharynx is preventing whatever item that triggered that pharyngeal reflex from moving downward or distally through the pharynx, which could lead to a choking event. Now, the literature is rather thin on this, but to the best of our knowledge, about 1/3 of individuals completely lack this reflex. 1/3 of individuals have this reflex. And then another 1/3 of the individuals have what's known as a hyperpharyngeal reflex. And so what that means is that it's more than just the pharynx that tightens. A lot of the abdominal musculature can tighten, and a hyperpharyngeal reflex can lead to an emetic event or vomiting. And that leads us to the assessment question of this video, and that is the palatine tonsils are most specifically located in what region of the head and neck? Is it the fauces? Are they between palatoglossus and palatopharyngeal folds? Yeah, that sounds pretty good to me. Nasopharynx? No. Oral cavity proper? No, that's too far anteriorly. Oropharynx? Yeah, technically, very much so. And laryngopharynx? No. So we have to decide between fauces and oropharynx. Well, fauces is a specific part of the oropharynx which contains the tonsillar fossa. So best answer A, fauces for the win. Thank you very much for your time.